minutes? I mean, to the agenda? Okay, hearing none, I'll entertain a motion to approve.
So moved.
Second.
Okay, it's been moved and seconded that we adopt the agenda. Any discussion? Any opposed? Hearing none. I'm sorry, we have to do a roll call vote.
Yes, ma'am.
That one in-person meeting spoiled me.
I know.
Okay, roll call vote.
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. McDougall, Mr. Curtis,
Yes.
Dr. Brightway,
Yes.
Dr. Orto,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
and Mr. Gregorio.
Yes.
Thank you.
Okay, motion carries. All right, you received the minutes and your email mail. So hopefully you had a time to review those. Are there any corrections to the minutes? All right, if not, we'll entertain a motion to approve our May 12th meeting minutes.
Jim Miller here, motion to approve. Or
Second.
Roll call vote.
Dr. Jackson,
Yes.
Dr. Miller,
yes.
Dr. McDougall,
Yes.
Mr. Curtis,
Yes.
Dr. Brightway,
Yes.
Dr. Orto,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
and Mr. Gregorio.
Yes.
Thank you.
Motion carries. Are there any public comments?
No, ma'am.
Director Jenkins, any staff program recognitions?
Yes, ma'am. Good evening, Madam Chair and members of the best board of health on this side of heaven. Just want to recognize that this is Men's Health Month and Durham Public Health has been in the spotlight. I may get in trouble for recognizing some individual folks, but I received a letter from Dr. Angelo Moore, and he just wanted to really thank Durham Public Health volunteers for assisting their event on Saturday and Sunday at Lincoln Community Health Center, where they had their men's health screening. It had been 2 years since they had one, and in his words, this event had a significant impact on our community. We provided free screenings for approximately 181 men. What a way to kick off Men's Health Month. So again, big shout out to this partnership and collaboration, but specifically, I'd like to thank Ashley Bueno, Patrice Carr, LaVista Clayton, Lee Antoinette Moore, Randy Rogers, Christopher Mack, Linda Hutchinson, Becky Posada, Shakia Brevard, Dennis Hamlet, and Adriana Dela Cruz. They were members of the public health department that spent 10 or more hours each day helping to make that event a success. So again, we thank them.
Yeah,
And
awesome.
round of applause for them. And then of course, last but not least, Mayor O'Neill reached out to me and wanted to see about if there was an individual or group that could receive a proclamation declaring Men's Health Month in the city of Durham. And of course, I could think none other than reaching out to Joyce Page, who is the coordinator for the Durham Public Health Men's Health Council, a very active council that I am proud to say that I am a member of, an active member at that. And on Monday, June the 6th, we were at City Hall Chambers, and Mr. Elvert Dorsey, who is the current chair, joined myself and other members of the Men's Health Council and Joyce Page to receive that proclamation from the City Council for the City of Durham. And it was a very nice event, televised, and I was asked to give a quick COVID update, but nevertheless, it was a great event. Just wanted to lift that up to the Board of Health. That's all I have, Madam Chair.
All right, great. Congratulations. Congratulations. That's excellent. In particular to the staff at Lincoln. I know they've done those screenings before. I don't know that they've ever had that kind of turnout in terms of the men that participated. That's great. All right, our administrative reports and presentations. First is Ms. Branch. Antrell Branch is going to come to us regarding our strategic plan update.
Forgot to take myself off mute. Give me 1 second. All right, let me see. All right, can you see my presentation?
Yes,
Okay.
there you
Hey,
go.
good
That's
evening,
better.
everyone. I'm Antrell Branch, and I'll be sharing with you an update regarding the strategic plan for our health department. So just to define strategic planning, this is the definition from the Public Health Accreditation Board, and it's that strategic planning is a process for defining and determining an organization's roles, priorities, and direction over 3 to 5 years. A strategic plan sets forth what an organization plans to achieve, how it will achieve it, and how it will know if it has achieved it. So why do we need a new strategic plan? Any agency can benefit from having a strategic plan because it allows for gathering of information that informs the work and provides clear direction of where we want to go as an organization. It also provides the agency with priorities to guide the performance management system. Also, a strategic plan assists with proper allocation of resources in alignment with a community health assessment and the agency's community health improvement plan. So the current strategic plan originally was going to be in place until 2025, but this decision was made prior to 2020. And so there were some leadership changes within the health department, and then the pandemic has occurred. So we felt that there was a need for our agency to really reevaluate our focus over the next few years. And so it was determined that we would follow the process for strategic planning that is recommended by the National Association of County and City Health Officials, which is a 6-step process. So step number 1 is to lay the groundwork for strategic planning, which includes identifying and defining your stakeholders and determining their engagement level. Also, in this step, it's determining what day project can. During step 2, you would develop the mission, vision, and values. And although we already have these components in place, we can revisit these if we see that we need to update them. And step number 3 is compiling relevant information, which includes completing an environmental scan by doing an assessment of the data and conducting a SWOT analysis. In step 4, we would analyze the results and select strategies after we identified and framed any cross-cutting themes and emerging trends that come as a result of the SWOT. And then step number 5 is the development of the strategies, goals, and objectives. And an implementation plan will be developed with timelines, and it would define how we would measure success on those strategies. In step number 6, we will establish the process for monitoring our progress on the plan, as well as establishing a regular quality improvement to improve our overall strategic plan process and outcomes. And we'll maintain flexibility, keeping in mind that this will be a living document and therefore revising and updating the plan as needed. And so this is just detailing what we have or what we're currently doing as we started this process several months ago. So the 6-step process was shared with leadership and then later shared with all staff back in February and March. So we conducted a SWOT with all staff in early April during our staff development day using 10 facilitators facilitators in breakout rooms in our Microsoft Teams because we did this virtually. And we formed a strategic planning team. You are or will shortly be completing a survey to provide input as well, as we need our Board of Health input as well. And our next steps will be to analyze the results. We'll complete our environmental scan, and then we'll determine the trends and cross-cutting themes, and then we will start to prioritize. And of course, we will make sure that we share the process with you all as we go throughout the process. We are hoping to have the plan in place by August of this year. So do I have any questions, comments, or concerns?
Angela, just one quick question. So how long, what time period will this strategic plan cover? How many years?
It could be 3 years, but we might determine that it needs to be 5 years. Usually it's 5 years for Durham County. I've seen all the other plans that have been for 5 years, but there might be certain strategies that might not be quite that long. They might only be 3 years.
Right. Okay. Okay. And so you said we will be receiving one. I don't think any of us have gotten a survey yet, but we'll be on the lookout.
Yeah, you'll be receiving it shortly.
Okay. Any questions for Ms. Branch? Okay. Good. That's good. It's like you said, it's the last one was done pre-COVID and all that, and a whole lot has changed since then. So that's good. You all are taking this on. All right.
Thank
So
you.
then next, thank you. Region 5 tobacco update with information about the proposed menthol ban. Ms. Natalie Rich and Aaliyah Brown.
Hi, good evening, everyone. I believe that my maiden name is listed in the agenda, but my name is now Natalie Thompson. So I'm coming at you all tonight with a new name and a new role. And I'm so excited to present to you all. So I'm gonna go ahead and set up my PowerPoint if y'all will give me a minute or two to do that. Okay, are you all seeing my slides correctly? Okay,
Yes.
great, thank you so much. So like I said, I'm Natalie Thompson. I am the Region 5 Tobacco Prevention Manager, and I just wanted to highlight for you all some of the successes that we have had with this new role coming to Durham County in the last year, and then also talk about a very timely topic, which is the FDA proposed menthol ban. So just to start out, the Region 5 tobacco prevention position came to Durham County in 2020. I have served in that role since December 14th of 2020. It was previously housed by Guilford County, but it's now hosted by Durham. And this role is really providing leadership and technical assistance to the 8 counties of Region 5. So that's Durham, Chatham, Orange, Alamance, Guilford, Rockingham, Caswell, and Person counties. This position has 4 goals, and these goals come directly from the CDC grant that is the source of our funding. The goals are prevent the initiation of tobacco use, help tobacco users quit, identify and eliminate tobacco-related health disparities, and eliminate exposure to secondhand smoke, right? So this is really my charge as the Region 5 Prevention Manager. So I want to talk about some successes that we've had in the last year in each of these goal areas. So I've been able to reconvene the Region 5 Tobacco Collaborative with representation from each one of the county health departments. I've also been able to add 4 new members to our collaborative, including Insight Human Services, which is a youth serving agency, which is really key to helping with that youth prevention piece. I've also enabled 3 of our collaborative members to become tobacco treatment specialists. They've gone through the Duke UNC tobacco treatment training program, just so that's better equipping us to help folks quit tobacco. I provided assistance and training to 2 Medicaid LME MCOs throughout the state on implementing tobacco-free policies and programs. And then my most recent project is partnering with North Carolina A&T and North Carolina Central University on an upcoming 2-year grant that will help them to strengthen their tobacco policy, their prevention programs, and their treatment programs for students and for staff. So now I'm going to transition from talking about those successes generally in the region to talk about something that's happening on a national stage. So the FDA is currently in the process of proposing a menthol ban, which would, when it goes into effect, would essentially ban menthol cigarettes nationwide. So this announcement was released on April the 28th, and it actually contained two proposed rules. One was removing menthol cigarettes from the marketplace, as well as removing all flavored cigars from the marketplace. So we know that the US is not the first location to do this. Canada has already taken this step. There's also been other counties and municipalities that have banned menthol. And so we have this research that allows us to make predictions about what we might see in 40 years if menthol cigarettes were no longer available in the US. So we would expect to see overall a 15% reduction in smoking and up to 654,000 lives saved from smoking attributable deaths. And that's up to 238,000 lives saved among African Americans. So now I want to talk about why we might have, or why a menthol ban would be proposed by the FDA, and then why.
Yeah, J.M. Paul, you need to mute.
Thank you. Why we would see a menthol ban proposed by the FDA and what impact that might have. So menthol, which I'm sure you all are familiar with, is this minty flavor that's added to a lot of tobacco products, and it actually has this action of numbing the throat, and it makes it a lot easier to inhale smoke. And because of this, it really entices and enables young people to use a tobacco product when ultimately, if they were to inhale tobacco smoke, it would be too harsh for them. So it's kind of like that starter gateway. It also makes it harder to quit. We know that folks who smoke menthol tend to inhale more deeply, and so they get more nicotine into their systems, and that leads to a stronger level of addiction. It also causes more difficult lung cancers to treat. It causes lung cancers that are more difficult to treat. Sorry about that. Because of that deeper inhale again. And then we also know that the tobacco industry has historically and continues to target vulnerable communities with specifically menthol products. And that's what I wanted to talk about in this next section, is the fact that menthol is a racial issue because African Americans have been one of the communities that have been most heavily targeted by the tobacco industry when it comes to menthol. So these are just some of the ads that I pulled out of magazines, off the internet, that really showcase the ways in which tobacco companies have manipulated elements of African American culture and music and tried to make this part and parcel of African American community life. And they've done a really good job of that. It comes from a belief that the tobacco companies have, which is documented in the documents that were released 20 years ago. And they believed that the African American community had low self-esteem. And so they thought that this would be a great target market for their products. And we know that today, 85 to 90% of African American smokers choose menthol products. So one of the questions that comes up whenever I'm talking about any kind of tobacco regulation is, okay, well, this is a personal choice. This is about, folks making their own personal decisions about what they do with their bodies, which is an understandable thing to say. And we know that nicotine is one of the most addictive substances on earth. We know that menthol makes nicotine more addictive because of the reasons that I just talked about. And we also know when we think about when folks tend to start using a tobacco product, it is during those teenage years before their brain is fully developed. And I would then argue that when you're addicted to something, that actually takes away an element of your personal choice because you're not waking up every day choosing to smoke every cigarette that you're smoking, right? You are doing it because you are in an addictive pattern. Another question that's come up specifically regarding menthol is, where will a menthol ban increase the policing of African Americans? And I think that this is a really valid argument given all that is happening in our country today and in the last couple of years. And I think that the tobacco industry has really seized on this specific argument, and it has exploited real issues of police brutality and mass incarceration. it's important to remember that the FDA cannot and will not enforce policies against individuals or consumers. The FDA menthol ban is very explicitly targeted towards manufacturers and retailers of menthol product. So no individual will be penalized for consuming or possession of a menthol product with this ban. We also know that research from Canada and other places that have banned menthol shows that this becomes an impetus for folks to quit smoking. So a lot of research out of Canada shows that it increases the quit rates for folks who smoke menthol products. So that means it could really save and prolong millions of lives. Will a menthol ban lead to a black market? This is another really valid question, because the last thing that we want to do is create a situation where we have a black market. And again, we can take some of the lessons from Canada and other places that show that there is actually a pretty low likelihood of a black market. And then we also want to consider that this isn't about eliminating every single menthol cigarette in America. Do I think that the menthol ban is going to make that happen? Probably not. But the reality is that we know that that menthol products entice youth. We also know that we're trying to create a culture in which young people are not starting to use tobacco, and the folks that want to quit are able to quit. And the way that we do that is that we put some barriers in place between young people accessing the products, and for folks who are trying to quit, we can add some barriers to them accessing the product as well, right? So we're trying to set folks up for success and not using tobacco. Is this another case of government taking away personal freedom? Again, coming out of the last 2 years of COVID with mask mandates and quarantine, a lot of folks are asking this question. And this is something that the tobacco industry really pushes in their promotion, that this, cigarettes are a right, they are a personal freedom, and we ought to have access to that as, a country that believes in freedom. Ultimately, I think that the tobacco industry is really manipulating us by saying this, because they're talking about a product that's one of the most addictive things on earth. And so when we think about that, it's almost like when you're addicted to nicotine, that kind of takes away your freedom, because you're not really able, if you've ever used a tobacco product or talked to somebody who has struggled to quit, they're not acting out of their own personal freedom when they're using that product. They're acting out of addiction. I would also consider, the tobacco company and the way that they view the folks who use their product. This is a direct quote from a tobacco company executives. We don't smoke this leaf, we just sell it. We reserve the right to smoke for the young, the poor, the Black, and the stupid. And then thinking about that attitude that the tobacco industry has towards its consumers, is this really an industry that we want to continue supporting? And lastly, I just want to talk about how a menthol ban aligns with those goals that I talked about at the beginning, our Region 5 goals for, my position. With preventing the initiation of tobacco use, we know that menthol is very attractive to youth, and that eliminating menthol reduces youth use. We know that, again, coming from Canada, we saw a bigger jump in quit rates among menthol users after they put in their menthol ban a number of years ago. We also know that because menthol products are targeted towards marginalized communities like African Americans and LGBTQ people, that eliminating menthol means that we can help to close those disparity gaps among some of these populations. And then lastly, if we're able to reduce in any way the overall tobacco use rate, that then means that we're able to reduce the amount of secondhand smoke in the air. And so the last thing I wanted to tell you all is that there is something that you can do. The FDA is currently collecting comments until July 5th, I think is the deadline. And so if you are so moved, then you are more than welcome to submit a comment to the FDA with your thoughts, especially if you have a background in tobacco as a medical provider, or family members, or your own personal use. If you wanted to add a personal story, letting the FDA know what you think the impact that this ban could have, and the history of damage that the tobacco companies have done in our communities. So if you feel so moved, this is actually a link to an American Lung Association form letter that you can use to submit, or you can use the same thing to edit it and put in your own comments or your own story. And then lastly, if you wanted to submit a comment as a board, or if one of you really wants to work on your own tailored comment, then I really encourage you to reach out to me. We can draft something together and submit it during the comment period. This is my contact information. And then the last thing that I wanted to say before we roll into questions is she wasn't able to be here tonight, but we did hire a new Durham County Tobacco Health Education Specialist, Aaliyah Brown, who's already been, she's been here for a few months and is already doing an amazing job connecting with the community. I look forward to having her come and present with you all as well. So at this time, I will take any questions that you all have.
Okay, thank you. That was very, very good and informative. So I have a couple of questions. One, so in Canada and other countries, have they seen a decrease in the amount of youth that are actually starting to smoke?
Yes, so Canada's ban was phased into effect over a couple of years, I think between 2014 and 2017, and they have seen reductions in young people using menthol cigarettes. Now, I will say that, with vaping, that does complicate matters, right? Because we're seeing increases in vaping, but ultimately, I think that any reduction in smoking is a win.
Okay, all right, great. My other question is regarding your position. So is that a rotating position? Will you be with us forever, or does it rotate amongst the 8 counties?
Oh, ma'am, I'll take that
Yeah,
one.
Director.
Yeah, go ahead.
One of the things that I did as health director is just really assess the talent that we have. And I couldn't think of a more talented person, more passionate person about tobacco prevention than Natalie. So we knew that the tobacco prevention manager in Guilford County was retiring, along with their health director, Merle Green. So I rallied to make sure that Durham was well represented, because I felt that we were well poised to have this position here. So it's not a rotating position, it's a permanent position. Funding does come from the CDC, little funding comes from Durham County, but delighted to have somebody as talented as Natalie leading the region.
Okay, yeah, and that was my other question too about the salary. So thank you. All right, great. Well, welcome, Natalie. We're glad to have you. Good.
And if it was up to me, I would be in Durham forever. So, and I hopefully will be as a resident for sure.
And as she mentioned, Aaliyah is just off to a great start. She's fantastic. So I think we hit a home run when we hired her as well.
Okay, great. But we look forward to hearing more about that. All right. Any other questions for Mrs. Thompson?
Madam Chair, I think we have 2 questions, one from Mr. Gregorio and one from Dr. Ray.
Okay. Oh, I see now. See those little hands. Dr. Ray.
Yes, sure. First of all, Natalie, great presentation. Learned a lot. And I think you mentioned this. My one question was about data around youth switching to vaping products, at least in Canada. Is there data available that and is there either locally or at the FDA level, do they have strategies to sort of address that conversion?
Yeah, that is a great question. So we do have some evidence that youth are maybe not necessarily, what we more likely see is youth starting out with a vaping product and then taking up a combustible tobacco product like cigarettes, right? So that's what we've been seeing. We've seen, the shift that we've seen is a reduction in cigarette use and a skyrocketing vape use, so that when you look at the overall tobacco use rate among youth, it has not changed very much since the early 2000s. What's changed is the type of product, right? And so, because we're factoring in vaping. So as far as whether, you know, young people will turn to vaping, you know, with a menthol ban, I think that that is a possibility because it's really skyrocketed among young folks. But right now we have dual settlement money at the state level that we are really excited to put into practice. Really, you know, getting a hold on this youth vaping epidemic in the state of North Carolina. So we have a lot of conversations going on about, you know, some different strategies that we can use that money for. But great question.
Great, thank you very much. And then my last question, you don't have to answer this now because it's probably a much larger question, is just around if and when this ban goes into effect, implementation of getting tobacco cessation aids and products to individuals that are impacted. You know, obviously that's a funding issue and all of that, but would love to just continue to have a conversation around that if and when that comes up.
Yeah.
That's a great question too. I mean, North Carolina has a really robust quit line. We're lucky, not every state does. And I will say that, you know, right now, anyone who calls the quit line gets at least 2 weeks of nicotine replacement therapy mailed to them for free, you know, and uninsured folks and, you know, folks on Medicaid or Medicare can get much more than that. But North Carolina is really lucky because we have great resources to help support folks quitting.
Wonderful, thank you very much.
All right, great. He went away somewhere, but Mr. Gregorio.
Yes, thank you, Ms.
there you are.
Hey, thanks, Ms. Thompson, for your hard work. Actually, Dr. Ray may have already asked this question, and you might have already clarified for me, but it does sound like this particular ban won't necessarily apply to e-cigarettes. Is that correct, for menthol? I see. Okay,
That's
gotcha.
correct. Yeah.
Gotcha. And as we all know, oh, absolutely. I mean, we know that, you know, youth certainly are adopting these e-cigarettes, and that tends to be more popular for them. So that's interesting to point out. Gotcha.
Yeah. So you know, for folks that vaping is sort of a new thing, and the menthol ban on cigarettes is seen as kind of a long overdue, should have been done in 2009 when other characterizing flavors were banned in cigarettes. So it almost feels like the FDA is trying to play catch up. As far as banning flavors in e-cigarette products, that is going to probably be more of an uphill climb at this point with the vaping industry. But yeah.
Fighting a good fight. Thanks so much.
Thanks.
Yes, yeah. Stay tuned for more. Thank you very much.
Madam Chair, we also want the board to know that we will provide you all with the links to the online comments and a separate email.
Okay, great. Good. All right. So we're now down to agenda item 7, public health vacancy report. Any questions or comments on that? I see there's still movement, so that's good. I'm sorry, vacancy report. What did I just say? I think I said public health NOV, didn't I?
I thought you said vacancy report.
Okay. So yes, I'm sorry. So yeah, on the vacancy report, we're actually down to 15.4. So we were hovering 16, 17. So that's it's just a percentage point, but it is something. It's good to see it going in that direction. And then of course the NOV report, like I said, there's movement on there still with environmental health and the work that they're doing. So. And
yeah, I'd like to just say,
I'd
just like to say a few words about the NOV report. We actually have had some significant movement in a few of those cases. We had one really difficult case that we had to file a lawsuit on. And it turns out not only did we prevail in that lawsuit, but we also were able to acquire fees and fines as well, and resolve the problem with the violator actually abandoning the the septic tank, and I believe they're going to demolish the building that's on it. But it was a little tricky because they had a tenant in the house. So that did take some time, but we are certainly still plowing through the NOV list. And the only thing I can do is just give kudos to environmental health. Before I started representing the health department, I had no idea how much they do. And they do a tremendous amount of work. So we are plowing through that NOV list, and I think there's some light at the end of the tunnel. So just want to let you guys know that when we get to the point that we have to file a lawsuit, then that's sort of an extremely serious case. So that was one of the extremely serious cases that we did get resolved.
Okay. All right. Great. Thanks, Brian, for that. All right. And thank you, Environmental Health. I can't see everybody now, but I'm sure they're here. And the Health Director's report. Any questions or comments on that? I did the Dine newsletter. I actually went and looked at some of those. You all do such a great job with newsletters. That is a nice newsletter. I did have one question though. I wonder because it's sent out through MailChimp, and so you have to have a computer, I guess, to get it. Is there a possibility that some could be mailed?
We will make sure that you get that newsletter, Madam Chair.
Okay, yeah, that'd be great. And I have a computer, so you can send it to me, MailChimp. But if there are other people that you see out and about at health fairs or whatever that are interested but don't have computer access, could we mail it to them?
We'll make it happen.
Could I answer that, Rod?
Sure, absolutely, Michelle.
Hey, Michelle.
Hey, we used to mail so many of them, but it becomes a privacy issue and a consent issue. And so we can look into it again with DSS, but we have to get individual consent from each SNAP participant because DSS would be
okay, I see.
address. So that's why we went to the electronic. And so part of it is just trying how to, get it out there more, but we can look at other options too. Just maybe having stacks of print a few and have stacks that people could pick up might be a good idea at places. So we'll look into that more.
Okay. All right, thank you. Oh, and the other thing that caught my eye was the survey, the client survey that you all recently did with 98%. I think 400 and something folk respond, and 98% of them thought that service was excellent or at least very good. That's great. And about a third of them actually wrote comments about how good you all are. So that's pretty good. You can't please everybody, but you all are pleasing quite a few, it seems. So that was good. Kudos on that. All right, any committee reports? None of the committees that I know of met, so I don't think we have any. Old business, COVID update. Y'all, I had my first COVID quote unquote scare in 2.5 years. I saw somebody over the weekend, called me a few days later and said they had COVID. So you're kidding me. So anyway, so I got tested yesterday. I was negative. No symptoms.
Same here, Dr. Jackson. I'm quarantining myself as well, but I'm negative for so far.
Actually, I ended up with 2 PCR tests yesterday because one I went to CVS and the other I went to Duke, and they both came back negative. All right, COVID update, Dr. Jenks.
Sure, thank you, Chair Jackson. Let me share my screen here. Can you see the presentation?
Yes.
Okay, I'll be pretty quick here. Here we go. So just to remind you, there are other metrics that we look at, wastewater surveillance, the state's looking at syndromic surveillance, but the main metrics that the CDC is publishing are, these three metrics that make up the community levels. So it's case rate per 100,000 population in the previous 7 days, new admissions per 100,000 population in the previous 7 days, and then percent of staffed inpatient beds occupied by COVID patients. And so our recent metrics, this is as of today. So we've got 419 cases per 100,000 over the past 7 days. It's up a little bit. It's been going up a little bit over the past 4 to 6 weeks. 13.2 admissions per 100,000 over the past 7 days. That is kind of waffled between 8 and 14 over the past 6 or 8 weeks. And then percent staffed inpatient beds is 5%, which is pretty low, and it's been down there the past couple of months, really from the first Omicron surge. Now, because our cases are over 200 and the new COVID admissions per 100,000 are over 10, that does place us in the high level, and we've been in the high level for, I think, about 4 weeks now. So this is a updated map as of today. You can see there's about two dozen other counties that are orange as well as us. So, it's majority orange or yellow, orange in the high level, yellow in the medium level throughout the state. And, over the past couple of months, this wave, so to speak, really started in New England. And, I've kind of noticed it's been tracking, farther south. And so there are counties in yellow and orange, below us as well in Florida and some of the other southern states. So the big change with high community level is, the CDC recommends, and we have been recommending for weeks now to wear a mask indoors in public, and that's regardless of vaccination status. The same recommendations hold true if you're immunocompromised. Wear a mask, avoid non-essential activities indoor, and have testing ready. If you're immune compromised, if you're going to be in public, or if you're not immune compromised but you're going to be around someone who's immune compromised, it's a good idea to get tested. So here you can see hospitalizations. Again, there's been a little bit of uptick over the past few weeks, not a huge increase. And then cases, an increase as well. We're about where we were during the peak of the Delta surge, nowhere near where we were during the peak of the Omicron surge, the initial Omicron surge over the winter. And I threw this this chart graph on here. I find this to be pretty helpful in kind of explaining what's been going on over the past couple months. For some reason, the B.1.1 or B.1.617 is not coming through here, but up here in the very corner, this that was the initial Omicron variant. This was the initial Omicron variant hit us during the winter, and then as that has started receding, the B.1.1.529 subvariant, took hold. And you can see here, this started about March and peaked, really peaked in early March, and then started fading as this BA.2 subvariant started sweeping through the United States. And as that started fading, not to throw too many acronyms at you, but the BA.2.1 subvariant started coming through and is probably not peaked yet. But we're already seeing some subvariants of BA.4 and BA.5. And I think these kind of sweeping waves of Omicron subvariants coming through is really explaining kind of the situation we're in, that, as one variant peaks and starts receding, a new Omicron subvariant comes through, peaks, and then recedes. And we're just seeing kind of wave after wave of these Omicron subvariants. And the problem is, unlike the previous variants, you can get infected with more than one Omicron Omicron subvariant. And so people that got infected with the initial Omicron variant over the winter likely are at risk of getting infected with one of these subvariants. Now, that's the bad news. And I think that's why we're seeing higher, case numbers. And, a lot of us had thought we would be seeing this time of year. And in fact, it's estimated, we're only capturing 1 in 7 to 1 in 10 true infections and cases. And so the true infections out there are much higher than what we're capturing. The good news is that, this built up immunity, both from previous infections and vaccinations are what's protecting us. And so most people getting infected now are having they're having mild COVID, and they're not getting really sick and ending up in the hospital. So that's why we're not seeing a huge uptick in hospitalizations. The other caveat to the hospitalization numbers are we cannot tell the difference between someone going to the hospital because they feel sick and have COVID, or someone that goes to the hospital for a completely unrelated reason that gets screened for COVID in the emergency department and diagnosed with COVID. And so some of these hospitalizations are capturing people that are incidentally kind of infected, that they may not even have any symptoms, but they're going to the emergency department because they need an appendectomy or they've got congestive heart failure. So the hospitalization numbers can be a little bit deceiving because of that. So that's just kind of an update on COVID. Not too many updates as far as, vaccinations. We're still vaccinating Monday through Friday. We're anticipating that on or around June 20th, we'll get vaccines in for our under 5, so we can start vaccinating them and get vaccines out to our community partners so they can start vaccinating our littlest people. And then we have still been giving out boosters. The majority of people, in fact, that come through here for vaccination are getting their boosters. These are the most updated numbers. So about 51% of people who identify as Black or African American are fully vaccinated. 76% people who identify as Asian are fully vaccinated. And you can see the numbers for Hispanic or Latin, and then people who identify as white. And then vaccination by age group is a little bit busy, I think, maybe to see here, but you can see, I really wanted to highlight the yellow bars. Those are our boosters. And so, particularly people over 50, we've, actually done, pretty good job of getting them boosted. And you can see this teal or light green here, this fourth bar, those are our second boosters. And so there are people in Durham who have gotten their second boosters. So just in summary, over the past month and a half, cases have increased due to these circulating subvariants of Omicron, slight uptick in hospitalizations. We're, currently at the high community level. And I predict, given, the fact that the BA4 and BA5 subvariants are here and they're, still at low levels, we're probably going to be in this, this situation for the next couple of months. I would guess, and I think most people are anticipating the BA4 and BA5 subvariants are going to become the dominant variants, and that's going to take some time. So we'll probably be, kind of waffling between the medium and high community level over the next couple of months, and then fall and winter are coming. And I would hate to predict, I'm not going to predict what that's going to bring, but that is cold and flu season. So I think this is, this is kind of where we're going to be at for at least through the summer and probably the fall. I am going to stop sharing here, and I'm happy to answer any questions that y'all have. I know everyone's probably sick of COVID, talking about it. It's okay if you don't have any questions.
I know. We just need to stay vigilant.
Yeah.
So there are no questions for Dr. Jenks?
I do have a question.
Dr. Braithwaite has
Yeah,
one.
Dr. Braithwaite.
Dr. Jenks, thanks for the information. And as you said, we are all tired of COVID, beyond tired. What would you say would be our metric for determining when we would start requiring, not just recommending, mandatory indoor masking? I ask as a parent of 3 kids headed off to camp soon. No one's requiring masks for camps. For travel, it's not required on airplanes. When would we consider it?
Yeah, I think that's a good question, and it's something we've certainly talked about here. I think one way to look at it is we're 2.5 years into this, and Durham's done a pretty good job, I think, of masking when we've recommended it, getting vaccinated, and we've now got, plenty of masks, plenty of vaccines, plenty of tests, and now we've got, some pretty good and plentiful therapeutics. And again, this, built up background immunity, from prior infection and from immunization. And so, this is probably going to be the new normal for a while. And, a couple of weeks ago, we were sort of waffling on the medium and high community level. And so, we were speculating that, we could, knew we were dipping into the high level, that we may actually, revert back to the medium level, based on kind of the hospitalization numbers. And so, we'd rather not, I think, make the recommendation of getting into this, mask mandate and then doing away with it and then having to, kind of keep going back and forth. I think the one thing that we're really looking at is hospitalizations. If hospitalizations are ticking up, or, hopefully this doesn't happen, but, a new variant comes through in the fall, for instance, that's really a bad match for our vaccines, for instance, we may have to take a look at that. But I think, given the situation we're in and the fact that hospitalizations are low, I think that's really, that Durhamites are, I think, generally following our recommendations. I think we feel like we don't have to do that yet. But I think the uptick in hospitalizations would be the warning sign where we have to say, okay, people aren't masking, or what we're doing isn't working. We gotta, we may have to mandate it. But I think that's our thought right now. It's a good question.
I concur, and I'd also add, Dr. Braithwaite and members of the board, we stay in touch with the North Carolina Department of Health and Human Services and the CDC constantly. And from a statewide perspective, there's just not an appetite to go back to mandating. They feel as if we really need to go back into that traditional public health posture, which is to advise and highly recommend. But again, we're not a centralized health system in North Carolina, we're decentralized. So we, on the local level, have the ability to make that call. And I don't think there's a week that goes by that I don't ask Dr. Jinks, okay, what are your thoughts? And we are certainly working in tandem and closely monitoring the situation just to make sure. And as I said to the city council on Monday, my commitment is still the same to the mayor and also the chair of the Board of County Commissioners. If my medical director and data team, epidemiologists tell me, Mr. Jenkins, it's time, then I'm going to make that call.
And the last thing I'll say is, Liz Stevens and I, we meet regularly with Dr. Cam Wolf over at Duke. And so we're getting feedback from him as well about kind of what they're seeing over there and what the situation is at the Duke hospitals.
Dr. James, just one quick question, just for my own education. What role does the health department play, if any, in prescribing and distributing any of the oral therapeutics? As those become plentifully available, but they're difficult to get a hold of, and a lot of patients just either don't know about them or don't understand how to obtain them. What role or proactive education are we playing in promoting those agents?
Yeah, it's a good question. We talked about this. We talked about this, back during the initial Omicron wave. It's a little bit tricky because, and I did this at my prior job at University of California, San Diego. We had a COVID telemedicine clinic, and we were prescribing monoclonal antibodies. But the thing that we really like to do is follow up with the patient, at least a couple of days after they got it, to make sure that they're doing okay. And then our nurses would follow up generally until they were off of isolation. And so it gets a little bit tricky if I'm prescribing them here, for instance, we don't have a good mechanism to follow up folks, because if they're not our patients here, it gets in a little bit of tricky ground. And so, we decided that it was probably a little bit too risky for me to be prescribing them, for instance. But, we were in contact with medical directors in some of the nursing homes, for instance, and I, offered, to them if they want some teaching or they want to kind of talk over prescribing these medications, I'd be more than happy to do that to, fulfill that role. It's a good question.
Thank you.
Okay. Any other questions for Dr. Jenks? All right, thank you very much, Dr. Jenks. So stay tuned for more. All right, under new business, any topics for our meeting in August? I was thinking maybe something with gun violence and public health's role, if there is one, or something related to violence. I don't know if maybe we could get, I forget the name of the group now that used to report to us.
Bull City United.
Yeah.
More than happy to
Maybe.
facilitate that. And our health education team under the leadership of Willa Robinson does a lot with gun safety. There's a group that does a lot. So we'll be more than happy to facilitate that, Madam Chair.
Okay. All right, great. Thank you. Is that something the rest of the board is interested in, or is it just me?
Yes.
Okay.
Yes.
All right, very good. We'll at least have that. Any other questions or comments for the good of the order? Nope, y'all are pretty quiet. All right, so remember, we're not going to meet next month. We plan to meet again in August. And as far as I know, that would be in person, right, Director Jenkins? The whole parking situation and all that would be cleared?
We will probably be in the throes of the parking construction, so it's best to allow that to be virtual as well.
Okay. All right, well, we'll plan for it to be virtual unless something changes with that situation or what we could do. We wanted to be in person again.
So
Attorney Warder.
We can certainly do it virtual as long as the state of emergency, the state of emergency is still in place. If that should change, then we'd have to pivot. I think there are different ways to do it, but as long as the state of emergency is in place, then we can continue to do it virtual.
Okay, all right, good. Thank you for clarifying that for us. All right. Any other questions or comments? All right, well, enjoy your July, hot July, and we will see you in August. Mr. Anthony, you get ready to say something?
I was going to make a.
Don't we have to motion to close?
To adjourn?
Yeah.
Oh yeah, I was just gonna let y'all go.
I'll make a motion to adjourn.
Second.
Okay, it's been moved and seconded. Roll call vote?
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. McDougall,
Yes.
Mr. Curtis,
Yes.
Dr. Braithwaite,
Yes.
Dr. Otto,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
and Mr. Gregorio.
Yes.
Thank you.
All right, motion carries. We stand